So you went in to look better, you come out with no vision and looking worse.
The risk is 1 in 300,000.
So one thing that's been debated a lot in the industry is, should you be using cannulas or should you be using needles?
The treatments that were higher risk were in the midline, in the nose, in the glabellar area.
And so I went into the accident and emergency department there and discussed with the various consultants what our protocol was for dealing with filler-associated blindness. And they looked at me with slightly perplexed. And they said, well, we never see this.
Hi guys, welcome back to the channel. I'm here again today with the face restoration surgeons, Dr. Rachna and Dr. Jonathan, and we are going to be talking about something really super hot, super important, which is blindness after dermal filler injections. So take it away.
So the area around the eyes is unusual because there are lots of connections between the different blood vessels, which we call anastomoses. And the problem is that when you're injecting filler, which you sometimes do under quite high pressure, you can send filler down one blood vessel, which then ends up crossing over into another, and it can actually end up going into the blood vessel that supplies the eye.
In the published literature, there's been about 191 cases since fillers started being used, and the vast majority was due to fat. But actually the numbers have been increasing. And particularly in the UK, fillers are not really well regulated in terms of who can give the treatments because they're not a drug, they're a medical device, which means that anybody can order a filler on the internet and give a filler to anybody. We are seeing more cases, and that's really unfortunate, but it is still very rare. Most of the time, the treatments that were higher risk were in the midline, in the nose, in the glabellar area, in the area around the eyes. So when you're having treatments to this area, it's really important to see somebody who's very experienced to do those treatments and somebody who can manage any complications. We've published an article recently on something called aspiration, which is a technique that some aesthetic doctors like to use.
The guys at home, they already know about aspiration.
Okay, great.
Can you give us a bit more detail about gauge products?
What the problem was with some of the previous sort of articles on aspiration was that different people were looking at different products and not pulling back for long enough. And what we've shown with our recent publication is that actually having something like an ultra thin wall needle, which allows the needle to be very fine still, but a much larger diameter on the inside, means that you can aspirate, and if you're going to get a flush of blood back to suggest that your needle is in a blood vessel, that will happen sooner with an ultra thin wall needle than it might happen with a normal needle, because you have to pull back for longer. And if you have a thicker product, you have to pull back for longer.
So one thing that's been debated a lot in the industry is, should you be using cannulas or should you be using needles? Mm-hmm. And actually, there's no published evidence to suggest that one is better than the other. What is clear is that you should use the right tool for the right job. So there are certain times when a needle is the right tool. It is sharper, but that may be what you need to get to the right place with minimal force and to make sure that you're placing your product in the right place. A cannula may be equally sharp if it's a very fine gauge one, and can easily enter a vessel as well. I think it's important to move away from this, I only use cannulas, I only use needles, because what you should be using is the best tool for the job. Not everything's a nail, not everything's a hammer, not everything's a screwdriver. You need the whole toolbox. Some of these people who end up with blindness actually get spontaneously better. I think there's a spontaneous recovery rate of something like 20%. The way the blindness happens isn't always because the filler has gone into a blood vessel. It could be on the outside of a blood vessel and squeezing it. Or it could have touched a blood vessel and it's gone into spasm, like when you have a migraine and it's just temporary and then it opens up.
A lot of the people who recovered their vision following vision loss immediately after treatment with filler had hyaluronidase injected around the area where the product was injected and to the blood vessel supply of that particular blood vessel that was injected around. And that alone was enough to improve vision in a lot of people. If they are able to use hyaluronidase straight away to the skin area, that may have an impact on improvement in the vision.
Because there's been a trend for aesthetic practitioners to start learning how to do something called a retrobulbar injection. So trying to get this hyaluronidase as close to the nerve and the blood vessel they think is affected as possible.
In the eye.
And that means going behind the eyeball and injecting at high concentration around those blood vessels behind the eye. That is something that we don't recommend, because if you as a practitioner have had a complication and you don't spend all day injecting around eyeballs, you probably don't want the first time to be when you're upset, nervous, anxious, and your hand's slightly shaking, and particularly when there isn't good evidence that it's going to make a big difference. So until we can say, hand on heart, that the science shows that retrobulbars are the way to go, people should not be attempting it. In fact, there's lots of evidence showing that retrobulbars probably don't work. And when you do a retrobulbar, you've got a needle. It's quite long because the orbit is quite long, and you've got to pass it in past muscles, past other blood vessels, and near the nerve, and past the eye. And you could puncture the eye, which could make things worse. You could puncture the nerve, which could make things worse. You could affect the muscles, and you could cause a bleed, and that in itself could make things worse. And we have one case we know of where somebody started all these treatments, and it turned out that the reason they started the treatment was because after the injection, they asked the patient, "How's your vision? Can you see out of this eye? Can you see out of this eye?" And they said, "Do you know, I'm not sure I can see out of that eye." And it turned out there was no problem, but they hadn't checked before the procedure. And this person had always had a spot, a missing bit of vision in one eye, but they hadn't checked, so they didn't know. And it was only when they were sent to an eye hospital and somebody had a look in the back of the eye with a lens, and they said, "Yes, but this person has something called a macular hole, which is where the fine part of the retina is missing." And then this poor person had had all these treatments which are potentially blinding for something so we are always very careful to check vision beforehand. If you're a doctor watching this program, medical legally, you're in a very bad position if you've taken somebody from something that might have spontaneously resolved and done a treatment for which there's no proof, and you've made them worse. And even if they get out the other side, let's say the vision is lost. If you've also put a needle in the eye can end up becoming inflamed, it can end up becoming shrunken, it can become unsightly, you can end up with the eye pointing in the wrong direction, and so in addition to having no vision, you end up with a cosmetic problem. So you went in to look better, you come out with no vision and looking worse. So
I'm just gonna pull things back a little bit, because what I want to just make it quite clear is that this is a really rare occurrence. So you're more likely to get knocked over if you cross a road. It's about 1 in 300,000 based on the current literature. You're more likely to get struck by lightning. So it's not a common thing. It's not something you should be scared of in terms of having these treatments. But what you want to do is you want to be able to see somebody who can deal with a problem if it happens.
When you have a problem at the back of the orbit, the eye might be lost, but and the eye can be lost quite quickly. The eye probably doesn't survive starvation for more than maybe 15 minutes, 30 minutes, something like that. It's not 90 minutes like we used to think, it's shorter than that. But there are other structures in the orbit which will survive longer, like the muscle that lifts the lid, for instance, like the muscles that move the eye, etc. And so it is potentially worth treating some of these things. And we know that treating with retrobulbar hyaluronidase can be helpful for those, but not necessarily for the vision loss. And so that's why retrobulbar is not all out, but it's mostly out for most people.
Okay, so why don't you take us through your protocol that you've just written?
We ask the person who's doing the treatment to get a quick assessment of what the vision is and what's going on, and they will probably show you, and we'll ask them in our protocol to demonstrate to you what you can do yourself straight away. And one of the most effective methods is to reduce the pressure within the eye, and there are different ways of doing that. One of the things that we have in our protocol is something called ocular massage. So ocular massage is basically pushing on the eyeball and releasing it. So that compression and release, and now I'm going to reduce my pressure in my eye doing that, but that compression and that release will try and dislodge any blocked blood vessel with filler within it. And that is something that should be continued for about 5 minutes minimum.
Another way of reducing pressure in the eye or help dislodge an embolus is to get the blood vessels to expand. And the way you can do that is to try to increase the amount of carbon dioxide in your blood. And so one way of doing that is to breathe into a brown paper bag. So while you're sitting there massaging away, you're also going to have a bag over your mouth and nose, and you're going to be breathing in that bag.
So we say brown paper, so it's quite good to have brown paper bags around in the clinic and not a plastic bag. And why is that?
You still need your oxygen, and the oxygen will diffuse through the brown paper bag, but it will increase the amount of carbon dioxide.
The other things that you will expect to have in a clinic, if this should happen, is drops and other means of reducing the pressure, which can be done in the clinic. So
the wonderful drops we talked about in one of the earlier videos, which could raise the lid a bit, the alpha agonist, those can actually be used to lower pressure in the eye. Beta blockers can be used, so there are a whole range of drops that can be used, but actually ocular massage is a very effective way of reducing pressure.
So the drops take time to work, so you want something that is quick. If the clinic has access to putting in the cannula into your vein, they may well give you something that is able to reduce the pressure called Diamox. That can work very quickly to reduce the pressure in the eye, and it's a form of treatment for vision loss for other causes. So in our eye clinic we would use that as a method as well. And then the rest of the protocol really should be something that is carried out under an ophthalmologist. So reducing the pressure by either releasing a bit of fluid from the eye, giving stronger drugs like mannitol to reduce the pressure further. But within the clinic, the most effective thing that your practitioner can do after getting you to do the ocular massage and potentially reducing the pressure by getting you to breathe into a paper bag is to try and dissolve the area that's being treated, and so dissolve any compression of the blood vessels and dissolve any filler within the blood vessels by treating the skin area, the entire area of the skin that is supplied by that blood vessel.
Sometimes what we do is we put people in hyperbaric oxygen chambers. So this is not something that I've ever done, but there are people who literally get put in the same contraption where we put people who've been deep sea diving, because by increasing the amount of oxygen in the atmosphere, you're hoping that more retina will be perfused.
Yeah, so we have a bit of experience with that for the skin, and it's been shown to be very effective for healing the skin areas.
When we're talking about number of units of hyalase, how many are we talking?
Hyaluronidase in the UK comes as 1,500 units, and when we're treating a vascular blockage in the skin area, you would want to be injecting something like 75 units in several spots to cover the entire area that's supplied by the blood vessel. So you give the whole 1,500 units.
I'm not sure you can overdo it, actually.
One of the questions that we get asked a lot in clinic is if I'm going to go blind, or when's it going to happen?
The vast majority of people who have lost vision from filler, it's happened immediately.
There are different ways of being blind. You may just develop blurry vision in the central area, you may lose vision in the central area, or you may just lose a part of the retinal perfusion, which means you'll only lose a little part of your vision. And because everything's doubled up, the way Rachna said, you may not notice that. We have patients who sometimes have treatments where they do lose vision in one eye and they don't notice because the other eye is working, and they just, So that's why it's important, as we said earlier, to cover one eye before you give the injection, cover the other eye so people know what their vision is. If you haven't given a treatment and you put your hand up and they say, oh, I can't see, then you know that. It's good to know at that point rather than after you've given your treatment. In a panic, it's very easy to forget stuff. So what we recommend in the protocol we've drawn up, we write down where you keep your hyaluronidase, so the dissolving substance, and how you should dilute it up, because people will forget these things in a panic. And the number of your ophthalmologist friend, and so there are certain, so you don't have to spend too much time thinking. You want to have a protocol, and that's what we've produced, which we're having published.
So the great thing is that every clinic should be able to have this protocol printed out for them to use and have that prepared, so you wouldn't be in the situation where you need to worry that you're going to lose your vision and that's it.
The number of fillers that people are being given is going up, up, up. But in the old days we didn't have hyaluronic acid, so we used to give fat, silicone and others, and those used to be a greater proportion of the problem. Now that people are switching to hyaluronic acid, it looks like hyaluronic acid is causing more, but that's because we're giving more of those, so it's like replaced, it's become the standard. But the cool thing about hyaluronic acid is that you can actually dissolve it, so you've got something you can do.
I read a paper once saying that 45% of blindness cases were in South Korea, Have you seen that?
Yeah, I know that we
Yeah,
have seen that.
absolutely. So yeah, that's because a lot of the treatments in South Korea are around this area.
But as Rachna said, this is hugely rare. You've never had a case. As a matter of fact, I used to work at Moorfields Eye Hospital, and I thought, this is an important thing that we have to address. And so I went into the accident and emergency department there and discussed with the various consultants what our protocol was for dealing with filler-associated blindness. And they looked at me with slightly perplexed, and they said, well, we never see this. Like, we don't have a protocol because and I said, well, I was thinking I need to make sure that everyone here is ready and prepared for these cases that are going to come in. We need to get the hyaluronidase. We need to have a protocol for this so we can save sight, because it is a leading eye emergency.
Very rare.
But they had not seen it. So I spoke to multiple consultants who just work in A&E, which means that they don't do anything else like we do oculoplastics. They spend their time dealing with emergencies, and they have never seen a case. And this is London.
The risk is 1 in 300,000, and that's based on global data for the number of fillers that have been happening.
One of the difficulties with those sorts of numbers is that it's predicated on our knowing how many injections are given to how many different people. How do you count it? Is it per syringe? Is it per treatment session? Is it per needle pass? So again, when you get down to the science of this, it's more difficult to know. And like we said, certain countries report very well, other countries may not report at all. In countries where you have practitioners who may feel less confident reporting, or there are strong incentives not to report from a business point of view. So you can see that we don't know, but what we do know is that it's very rare.
Yeah, I mean, it's a hot topic, it's an important topic, but it's not something that your listeners...
It shouldn't keep you up at
audience
night.
should be worried about. No.
Cool. Excellent. So there you have it, guys. Chill out. That's all we've got time for this week. I hope you enjoyed the video. Let us know if you have any questions or comments for the surgeons here. Let us know in the comment section below. And we will see you again next week. See you later.
Bye.